Okay, and we are live. We are live here on LinkedIn. We are live here on Facebook as well. And we're coming to you again with another live broadcast of the Nursing Home Podcast. And we're here to examine a new facet of coronavirus outbreak, which is wreaking havoc on the entire world, on the United States and the rest of the world. And specifically, we know the tragic results it's having on the vulnerable population that resides in the nursing home setting.
Mhm.
Today, I have the opportunity to bring on an old colleague, someone that I've worked together with, an expert in her field, Marcia Amarsingh. Marcia is the president at Renewal Sober Living, and Marcia has really devoted her life to dealing with the challenge of substance use or abuse. Um, I'll let her talk for herself in a moment. But what we want to focus on in this conversation is the ever growing challenge of seniors that are also have a challenge with substance abuse, and how, if at all, that is affecting the level of the challenge right now in the nursing home. So before we even get too far, Marcia, welcome to the Nursing Home Podcast.
Thank you so much.
Yes, it's a pleasure having you on the podcast, and it's a pleasure having a conversation with you again about this topic. I mean, I know the training that you did with us, we spoke about for quite some time, and you really empowered our staff to identify and deal with some of the challenges which are new in the nursing home world. But let's talk specifically about coronavirus. And tell me, I know we mentioned before we went on the air and last time we spoke about how substance abuse might actually be exacerbating the challenge that facilities are facing. Can you tell us a little bit more about that?
Yeah, so you know what I call this, Shimal? I call it the two epidemics, because we had substance abuse that was somewhat an epidemic before, with the opioid crisis, and now we have the COVID-19. And I do think that the COVID-19 is affecting the substance use population as well, so much more significantly than others, just because of their vulnerabilities, the homelessness population that we have, and just the continued use of substances that has damaged the internal organs of their bodies.
Hmm. Hmm. So now specifically, is the it's true. So we have two separate pandemics, or because you have the challenge of this substance abuse disorder, misuse, abuse. I'm not sure what the right term is, and I'm sure you have an opinion about that. But that's something which is new. We're not used to seeing that in seniors, and that's getting more and more prevalent. And that's a challenge every day, and that's something that nursing home residents and nursing home staff operators have to look at, and it's a whole new set of challenges. Is that more challenging now with coronavirus, in the era? And is that bringing it into the nursing homes more than it would have if this challenge would not exist?
So we have to look at the population that we have right now in the nursing home. And we know that about in 2013, which is 7 years ago, a study was done by the Home Data Compendium, and they concluded that 13% of the nursing home population was less than 65 years old. We also do know that 30% of the elderly population, which will fall into the baby boomer category right now, have a history of substance use. So our nursing home population has traditionally changed. So yes, because again, because of the population and the vulnerabilities, the COVID-19 is definitely wreaking more havoc on the nursing homes.
Mhm, mhm. Now, there are people. What about healthy people who are relatively healthy people who are maybe homeless, and they're substance abusers. They end up in the hospital, pick up the coronavirus that's there, and then unfortunately, so there's really a bigger issue here at hand. Let's open this up a little bit more. There's really a bigger issue here at hand, and this is something which on some levels of government, they're trying to address this, is that we have a lot of people in nursing homes that don't belong in nursing homes. Like you just said, 13%
Yes.
is 65 and under. So what are they doing in nursing homes, right? I know as an administrator, and from your experience in nursing homes, I'm sure some of the listeners know this. A lot of times you walk through a nursing home and why is this person doing here? And a lot of times they present sometimes, the ones that don't belong there, a lot of the challenges, and normal, that's a normal thing, rightfully so, because they're alert and oriented, and they're not stimulated enough, and they have to find other things to be stimulated with. So that itself is a
So
challenge.
what I do think, and it's really sad to say this, but the nursing homes, traditionally the skilled nursing facilities, have been used recently by the hospitals as a dumping ground. And so, because they do not want to discharge these residents in, unsafe discharge, they call it, they find something that's skilled, which is maybe skilled for a day or two, send them to the nursing home, and then it falls on the nursing home to be able to find someplace safe to discharge them as well, because they too cannot have an unsafe discharge.
This is why I love having the nursing home podcast for moments like this, because over here we could say things the way that they are, and this is why the listener base is growing so rapidly, because what you just said is so true. The hospitals have a responsibility, a moral responsibility, and a legal responsibility to ensure that they're arranging and organizing and facilitating a safe discharge for every resident, for every patient that leaves the hospital. Now, if you have somebody who doesn't have a home and they're somewhat overall shaky um, health status, so just the fact that they're 52 years old and have a history of several decades of substance abuse is not going to stop the hospital from sending that resident to the nursing home. And mind you, the nursing homes still are filled with what we call, the little old ladies of yesterday. There's still plenty of 80, 90-year olds that are, for the most part, long-term residents. They're pretty healthy. And this is when they need, they need that level of care where this is where they belong, and it's the correct setting for them. But then you add someone who completely doesn't belong there, and this, let's leave, COVID-19 out for a minute, but that itself makes tremendous challenges when you have, um, how do we say this? When things sometimes can go missing. I don't want to stereotype or paint with broad brushes, but I was taught, and just after experiencing this time and time again, that there's a series of other challenges that come along that affect others that come along with substance abuse. So it's not like, oh, I like drinking, so I'm going to drink in my room and I might be dancing on my bed and doing my thing, but I'm not affecting anybody else. This really affects other people. But over here, you can have someone. Let's just think of it this way. In New York right now, um, Marcia, you live here in Massachusetts, right? Right, right
Yes.
in the Worcester area. But if you saw in the media, if you look in New York City in the subways, they've turned into, I won't call them homeless shelters, but a lot of people who don't have a home have moved in there, and it's not pretty to ride the subway now. So although I'm sitting here at home with my family and we're literally not leaving the house, maybe going to the backyard and only leaving the house for essential grocery shopping, with really no exceptions. So for most people, that's what they need to do to stay safe during this time. But imagine if someone lives in the streets. They're not putting on a mask. They're not putting on gloves. They're not concerned about this. Being infected by coronavirus is probably not on the top 10 list of their concerns, and it's a sad state of being, but it's today that becomes a dangerous state of being, because that means that they're very likely carriers, or they've been exposed to this super contagious lethal disease, so that when they do come into the hospital, which they always are when when a little bit too much substance is abused, and then if they get sent to nursing homes, it's almost like you're injecting coronavirus directly into nursing homes. Am I exaggerating this problem, or is this really what's happening?
That is what happening. And let's talk a little bit about shelters, because if they're homeless, we, especially in Worcester, we have one shelter that's operated by SMOC. It's 25 bed. It's 25 beds only. So
Mm-hmm.
we have approximately 38% of the persons that are in the shelter with a history of substance use. And we know that with that congregate setting, it's just a breeding ground for COVID. So we're having those residents who, COVID is running through the shelters, they're hospitalized, but because of their extensive opioid or other drug use, they have had maybe endocarditis in the past, which makes them having some now cardiologic, cardiac issues, or other internal organs like damage to their liver by drinking, or their kidneys. And so now for, they go hospital and then transferred to the nursing home for continued treatment or rehabilitation. So there we go again, having that population back in the nursing home.
Well, so are you actually seeing this in that particular shelter? That are they sending out their residents to nursing homes, not to hospitals, during COVID-19? They are.
Yes, they are.
Well, wow. So, and the question is, it? So I guess on under normal conditions, I'm sure they're sending residents of the shelter out when appropriate. But my question is it more? Are they being sent out more because they're developing symptoms, or is it just business as usual? And because of their uh, lifestyle, I guess they're more likely to be carriers.
Right. And so they, because of the congregate setting, even with homelessness, they group together. They're not doing social distancing and maintaining, 6 feet apart. They have no mask, they have no gloves, they have no protective equipment. They're just there on the street. And so the shelter, because the shelter, you have to go in like at 6. You can't be in the shelter all day. So you are out in the street, you're, intermingling, and at 6 o'clock you're going to the shelter. It's a congregate setting. You have, exposed to COVID. It's right there. Then, you go to the hospital, and the hospital will send you to the nursing home, and the cycle continues.
Wow. So that's a very powerful point that you're making because they have to leave. They don't have a choice. First of all, in the actual setting of the homeless shelter, like I said, there's no social distancing, the masks and gloves and whatever. And frankly, in my house with my children, we're also not doing social distancing, but we're all in this together. And if we leave the house, then obviously we are. But within the house, that's not possible. But so if we stay here, as long as we stay here, that's fine, which is what we're doing. But imagine if we do that and then we go out and we're literally out in the streets all day. And you know what? They're not even going into buildings. I mean, I don't know, exactly where they're going all day because there's not so much going on. And then they come back in at the end of the day and they
No.
kind of re-expose each other. So that's something that can be a challenge. And if they end up in the hospital, they go to nursing homes. I mean, this is a tremendous challenge. Let's just shift gears for a moment and just focus on the more broader subject of substance abuse in the senior population. What is the biggest challenge that presents to the nursing homes in caring for these individuals? And what are some things that the nursing home staff can do to identify and properly react to these problems?
So first of all, the nursing homes have to have policies implemented for substance use. They have to have trained staff to deal with this population. The CMS regulations are very old and did not cater for this population. So it's very hard working with the present CMS regulations and treating substance use because, for example, you can't do searches, body searches. You can't stop their visitors from coming to the building unless really you make a point that they're unsafe. You can't prevent residents from leaving the building and coming back. And so, say for example, we have residents who suffer from endocarditis, and the only reason they're there is because they need IV antibiotics for 6 to 8 weeks. So they're very healthy apart from having the IV, in their arm or whatever. And they walk around, they leave the facility, they go into town, they come back. And you really can't stop them from coming. As long as they're there to get their regular IV medication, you can't say you can't leave the building. So how to get staff to do this? It's very difficult, um, because DPH again is right down your back, so there you can't infringe on residents' rights. So it's very difficult
It
to
is.
treat this
It's a
population in the nursing home.
Yeah, I mean, I remember such a case actually. I was an administrator in Worcester. I don't know if we ever spoke about this. And we did have a resident that was there exactly your case. We actually had a methadone clinic across the street. I don't know if you know which facility I'm talking about. Um, but we had such a case where we had what we thought was an elopement. It ended up being one of these residents that was who had was there for IV antibiotics, going out into the street and came back at night to get his meds. But who knows what went into that IV when we weren't there. And if
Right.
something happens in the facility, we own it. So it really doesn't make sense. How could you be responsible where you have, resident rights says that he could leave, he or she could leave, but that was um at the same time, from a clinical perspective, if the resident goes out, then it's our responsibility. So yeah, so I guess the question is, so how do first of all, I'm assuming that eventually within the next 50, 60, or 70 years, CMS will update their policies and be more current. I'm assuming that's something that
I would
will be in the works soon. But but for right now, what can a facility do to actually manage this stuff? Because, like you said, you can't check their stuff, and you have a certain visitor that you're concerned about. You want to see what's in the bag. You can't look. So now what?
right. Right. And on the flip side too, medicated assisted treatment is now an official disability. So technically, the nursing homes are really not supposed to deny them on that basis.
Yeah, but you know what they say? They said there's no appropriate available bed for this resident. You just keep it vague. The same way you're not supposed to deny somebody if there's no payer, right? And if let's say there's
Yes.
Medicaid pending, which means that a lot of times the social worker in the hospital filled out haphazardly the application, but we have no idea if they own a house or if they have $1 million in the bank. They skip. I've seen this myself. They skip the financial part of the application, and then we have someone who's here now. We know we're not going to get paid. We're going to be in the red thousands of dollars, so we don't have an appropriate bed because it doesn't work, whatever. So, but you're right, technically they can't deny it. Well, is there anything, let's say for a regular nursing home operator, they're concerned that they may have substance abuse actually going on within the facility, maybe illegal trading happening in the parking lot or through the windows. They might be concerned, about the nurses. The nurses are very vulnerable and they have a med cart. They don't want the nurses to be physically in danger. Is there a good way for operators to, let's say, for nurses, social workers, anyone in the nursing home space, to help identify who might be someone like this, and what are some legal steps that nursing homes can do to address it?
So one, the staff can be trained to identify areas on the body that they could look out for like needle marks. You could look for needle marks. You could look for burn marks. You could look for how presentation of the body. Look in their eyes, whether their pupil is dilated or constricted. You could look at just how they present. There are particular symptoms of intoxication, and so once they're intoxicated, you can actually drug test them. And if they're high, you can send them to the hospital for clearance, so that you can take those steps. The other thing you can do is to look carefully at visitors. So visitors present clear profiles. If it's a relative, they usually visit for much longer. If it's a dealer, they'll be in out quickly. Also, you look for gang affiliations. You look for whether or not this resident now has more money or more electronics, or whether they're exchanging drugs for items, if they're stealing on the unit from other residents. You look at relationships on the unit, whether this elderly person is now suddenly befriending a young person and what they have in common. So it's a lot of just observation and relationship building that will allow you to recognize this. You look for cars coming in the parking lot, whether they're going out to meet these persons, and if it's a quick move, if they're out in and out, and then you kind of study that. It's almost
Well,
like investigative work. Yes.
Yeah, but I think a big piece of this is awareness, because knowing that this stuff exists, it exists in nursing homes. I remember the first time I had such a thing in a facility where someone actually overdosed and had to be literally, I saw him, I saw the resident gray as a sheet. And I'm completely, so just from my background, I have almost no exposure to any of this, and I am so naive. I
Mhm.
was so naive about everything, about how it works, who does it, how you do it, the effects it has, the difference between one and the other. I'm still not an expert, but I got a little bit of an education by being in this environment, and some of the staff, told me a thing or two about how the stuff works.
Mhm.
But the last thing in my mind that I associate seniors with my grandparents, right? And they certainly did not have any connection to this. So one thing is understanding that it exists, and it's becoming more and more prevalent, because these seniors were not seniors yesterday, and the habits don't disappear with age. So understand that it exists. That's A. B, it's very possible it exists in your nursing home. C, it not just affects that resident. That resident, like you said, it might be
Mhm.
one. If you see an 85-year-old resident befriending someone else who just came in, um, or like we had a case, uh it was clearly a gunshot wound to the chest, but they called it, I forgot, they had a different word that they called it, but I know the nurses looked at it and they're like, I forgot what they called it, a knife wound or something, I don't know. And then you see funny relationships happening, then you should be
Mhm.
concerned. Now you're saying there are things you could do, so you can take a drug test. Can you force them to take a drug test?
No, again, you can't force them. That's infringing on their rights. But you can, if they are presenting as intoxicated, you can send them to the hospital for clearance. You can do that.
Okay, so the problem is, I mean, administrators are reluctant to do that because 9 times out of 10, the hospital will have one look at them and say there's nothing clinically wrong. They'll send them right back.
They will. They'll send them
Yeah.
right back.
So and that affects the
I've
relationship
seen that
between the.
many.
Right, but I'm just saying from a marketing standpoint, like an administrator or admissions person would be concerned about that, because then the hospital doesn't like them. Why do you send them here? It's a bounce back to the hospital. And we don't want to see them here if it's not really medically necessary. Now, what the facility gains is that it shows you mean business. You're actually, the resident sees that you're going to do something. If we think that there's a problem, so you really have very limited options.
Yes, it is. That's what it is. Yeah. And then too, a bigger problem that I've noticed recently is that since we have the prescription monitoring program where the doctors are reducing their prescription for opioid medications, the nursing homes have kind of become a drug seeking place too. So the outside dealers will try to come in to get the medications prescribed, because a lot of the persons in the nursing home are prescribed opiates and recently gabapentin, which is kind of the new drug of the trade. And so the dealers will come in, they befriend the residents, they try to get their gabapentin, their opiates, they bring stuff for them and they go. And so it's now almost like a feeding ground for persons who are coming in too to get that kind of relationship with a dealer.
So explain that to me a little bit more. So what's the change that occurred that's making this happen? Did you freeze on me?
So so the prescription monitoring program was implemented in 2016 because of the physicians just prescribing a lot of opiates to people who really didn't need it. And so now they're being regged, flagged. A lot of lost their license to practice because of that. So now they're cautious in how they prescribe. And not only that, we have checks and balances. So the doctors prescribe, there's a database that they go in, they have to enter the medication, the client's name, and the reason why they prescribe these opiates or other scheduled medications. And the pharmacists, the dispensaries have to do the same. So they're holding people accountable now for overprescribing these medications. So it's cutting down on this availability for street drugs, for street, because people used to get these scripts and they and they would just sell dealers on the street. But now it's not as common. So they go to the nursing homes where they know for sure that the residents are prescribed those medications. They come in and they ask these questions, and they encourage residents to cheat the medications and give it to them.
Got it. Well, thank you for explaining that. Interesting. So you're saying that there used to not be a database, because I know that's there were times where they say that you have one resident that will go to the facility physician and get his medication, and then go to CVS and fill it from his community physician, and then try to get it again somewhere else. You see now,
Right.
now,
It's
now we
harder.
can't do
I'm not
that.
saying it's totally happening. It's harder.
Hmm. So now it's more difficult to do that, and therefore there's a bigger motive for it's simply harder to get what they need. So that's another reason for them to come in. And one of the things also that a concern that I've heard from my staff is that a nursing home is such a soft target. It's like, especially you come into a nursing home at 1:30 in the morning. Who's there from the, how many staff are there? A couple of nurses, a couple of CNAs, maybe you have 7, 10, 15 staff total, and they're very spread out. They're in the rooms. They're supposed to always be locking the med cart if they really want to and forcefully gain entry to the med cart. It's not difficult. So, nurses are concerned. I mean, and through
And they have a
proper,
right to be.
go ahead.
They have a right to be, because many of these guys coming in are really young, strong, guys who have a history of incarceration, a history of gang involvement. You see them clearly come in with gang tattoos, and you never know who's waiting in a car outside for them. So, of course, a lot of nursing homes have gone to employing security to be at the front of their the building right now.
Hmm. Now, for some of the listeners right now, and some of the people watching us right now live, are thinking that what you're describing might be for only specific, geographical areas. Is this really as prevalent all over the country as it is here, or are you referring to a specific area where it's more prevalent than maybe other places?
So I've worked in homes in 3 states, Connecticut, Rhode Island, and Massachusetts, and I've seen it all three.
Uh huh. So we shouldn't fool ourselves and think that it's only in certain places. It is prevalent, and you have to.
Not
Now, I think part of the challenge is that I think as an administrator, I think I'm not unique. There probably are lots of other administrators who who are managing the facility, but maybe are not so aware of some of these challenges that exist in society. Maybe some of the nurses understand it, but I think it's important that it should go from the very top of the organization to the very bottom. Everybody should be on the lookout for this. Now, it's not limited to that, right? There, you could have staff that are involved in this. You could have drug diversions, right? You could have nurses who are involved with residents.
that's too. Yes, because staff can have substance use disorder problems too, and so they too can have drug diversion, and that's actually very, very common right now in the nursing homes as well.
Yeah, and I mean, you put that together, if you have a nurse and a resident that's working together on, you know, doing whatever they can to a drug diversion to get stuff to get stuff out of the from the facility. In other words,
The
the
med
kids
card.
yeah, the case I'm talking about is that the nurse is a do-gooder. The nurse is trying to help and cure and save, which is the case with most people who go into this industry. What happens if this nurse also has this problem? And now this wonderful nurse actually is very interested in some side income, maybe some side benefits, and can work together with a resident. And it's the nurse's family or whoever it is that's involved in the parking lot in the car. Um, the incident I referred to earlier, where we had an overdose in the facility, um, the social worker remembered, like, after the story happened. I think it was like 4 in the afternoon. She remembered at like 3 something. She saw a car in the parking lot, and there were a bunch of people around it, and she thought it looked suspicious, but she was busy, like a social worker is, in a nursing home with a million things. Then afterwards, she felt so bad. She was like, maybe I should have known, and my job was to tell her, whatever happened happened. Let's move forward. And the funny thing is, the next morning, I was very concerned about what happened here. If someone would pass from uh, substance overdose in my facility or in any facility, that's definitely medium material and DPH material, and it's just not something that you want to happen. It's a bad thing that should happen anywhere, but certainly if it happens in the facility. Next morning, I got a phone call. Shmuel, do you have my wallet? I'm like, who is this? It was that resident. He wanted to know, could I come back? So we had to have a conversation about that. Anyways, Marcia, I really appreciate you coming on the Nursing Home Podcast. Any final thoughts you want to leave our listeners or our viewers with before we let you go? And then you'll tell us how they can find you and learn more about you and your business.
So substance abuse is a real problem. I know COVID is at the forefront of everything that we're experiencing now, and I'm not going to minimize that. It's terrible. But also, substance abuse is also very, very terrible. And I would really want all of us to pull together in the way we're doing with COVID to be able to help persons suffering from drug addiction. I know this is a terrible time for substance abusers too, because of the social distancing, and isolation is one of the biggest triggers for relapse. So I know for sure we're having an increase in um, overdoses, an increase in relapse, but also an increase in suicide. So I just kind of want everyone to be aware of this, and if they have any relatives or friends or just anyone that they know who suffer from this disease, just to reach out right now. It's very helpful in this crisis.
Wow. Wow. Little some sobering thoughts here. This is it's challenging for them at any time, but especially now without all the social interaction. Suicide,
Yeah.
overdose. I mean, these are very serious issues. If our listeners want to learn more about you, Marcia, where should they go? Give us your website or wherever they can find you.
So I have a sober house. It's Renewal Sober Living Inc. And we have a website for that. I have a private practice. It's Amarsingh Integrative Counseling Services. And I recently opened a mental health clinic. It's Renewal Integrative Psychotherapies. So my email address is aicsllc@outlook.com. And my phone number is 508-981-3301. And the renewal, it's a MASH approved sober house. So once you go on the MASH website, or you just type in Renewal Sober Living Inc., everything will pop up.
Amazing, amazing. All right, we'll put all the contact information you just shared in the show notes. And before we let you go, I just want to speak directly to the listeners and the viewers, whether you're on LinkedIn, whether you're on Facebook, whether you're listening to this later when this episode goes live. You can see this episode and every other episode that we've done live or not live at the nursinghomepodcast.com. Again, simply the nursinghomepodcast.com. And there you can see all the other facets that we've discussed. And if there are any particular issues that you want us to dig further into, reach out to me on LinkedIn. You could Shmuel Septimus, you put in my name, and you'll be able to easily send me a message there, and we will do our best to cover those subjects. So again, thank you, Marcia, for coming on and really shedding some light